I'd like to introduce Don Melady. He is a professor of emergency medicine at the University of Toronto, Mount Sinai Hospital. He is co-founder of the Geriatric Emergency Medicine Interest Group for the Canadian Association of Emergency Physicians and founder of the Geriatric EM Interest Group for the International Federation of Emergency Medicine, as well as creator of a phenomenal website, GeriEM.com, that we are going to be talking about in a minute. He is co-editor of the textbook Geriatric Emergencies, a case-based review, and co-faculty with me of the Geriatric Emergency Department Boot Camp with the John A. Hartford Foundation. Don has been gracious enough to come to St. Louis in November to be part of this day, Senior-Friendly Emergency Care, what you need to know about clinical care and system change. And by you, Don and I, we mean emergency medicine physicians and nurses, hospitalists, geriatricians, primary care, surgery, home health, case management, hospital administration, physiotherapy, and on and on. Geriatrics is really a team-based sport. This isn't something emergency medicine is going to be able to do alone. So, Don, welcome. I wonder what made you so passionate about improving senior-friendly emergency care?
Good morning, Chris. Thanks for inviting me to participate. So senior-friendly emergency care has always been a big part of my life. I'm a regular emergency physician, just like everybody else. When I'm on duty, I see everybody, trauma, children, women, men of all varieties. I guess, but my principal interest has always been older people. Older people have always been an important part of my life. My family story is such that I came from two very large families and at one point had 32 aunts or uncles over the age of 75. So I've always been surrounded by a lot of old people and came to know a lot about their care as all of those people went through the various components of healthcare. I think, though, from a professional point of view, there are two things. I think emergency medicine has always had a particular focus on providing care to vulnerable populations. It's the only place that's available to everybody all the time. And I think one of the main groups that we look after are disadvantaged people, so poor people, homeless, in Canada, First Nations people, substance addicted, homeless people, as I said. And really, I've come to think of the elderly population as a vulnerable population. They're vulnerable from a physiological point of view, but also psychologically and socially. And I think often emergency physicians are the main people looking out for their interests. So that's one thing from from an ideological point of view. From a purely practical point of view, I think we need to recognize that older people are really the core business of emergency departments. Emergency physicians have this mythology that their target population is the healthy 45-year-old man who accidentally drives into a truck. But we all know that's not true. We repeatedly hear physicians at the end of the shift say, "Wow, I saw so many old people on that shift. It was amazing, incredible." And yet, that's every shift.
Yeah, every shift I take over, people make this point that, hey, Chris, we're giving you the geriatric board today. I'm like, every day is the geriatric board. I hear the same thing every day.
Yes. So we really need to start owning this reality that in every emergency department in North America, every day, 20% of the people who come there are over the age of 65, and face up to the reality that in the next 20 years, and it's important to say every time, the geriatric boom has not yet started. So if you think you see a lot of old people now, you just wait 10 years. So we need to own this reality that every emergency department is a geriatric emergency department. They're the largest number of people who come. They are the people who take up most of our time, most of our intellectual resources, most of our investigation resources. They're the people who get admitted most often. They're the people who stay in the hospital the longest. These are our people, and we really have to get good at doing the best possible job, not just because it's the right thing to do ideologically for this vulnerable population, but it's the only way our emergency departments are going to stay afloat in the next 20 years.
Yeah, I concur. That's why I've committed so much of my career to better care for the older adult. You have spent a lot of time developing this jerryem.com website, which all of the attendees for the event in November are going to be able to go to and check out before the event. And I highly encourage the residents to at least go through a couple of the modules because I think you'll get much more out of the day in November if you do so. Tell us a bit about jerryem.com.
So for the last 10 years, I've run a seminar series for our third year residents, and that's 12 hours over the course of their third PGY 3 year. And about 5 years, I got a grant to take that collection of teaching material and turn it into an online resource. So that's what journeyem.com is. It's 6 modules. Each module takes about 30 minutes to complete. That knocks off all the heavy hitters, the big numbers in geriatric care. So things like assessment of cognitive impairment, medication management of the older person, trauma, which really means falls in the elder person, how to do functional assessment and do safe discharge planning, the physiological and practical issues around atypical presentations, and finally, end of life care and symptom management. So they're all very fun, interactive modules. Most people like them. There's been about 5,000 people have registered for the site. I've handed out. It is a fully accredited website, continuing medical education website. Can you hear me? Can you hear all that background noise?
Yeah, there, I can hear the truck going by. That's all right.
Hold on. Why they had to decide to cut down the tree right outside my house at this very moment, I don't know. They're fairly fun to do. They're quite interactive. It's not like watching a boring lecture on screen. They're interactive. There's lots of simulation cases in them. There's a pre and post quiz. There's an opportunity to find out what other. One of the things that our residents really like is that anonymously, other people's responses are recorded, so you can see what your peers are thinking about this topic, and an opportunity to interact with your peers. So, in general, they're kind of appreciated. For the faculty in the group, they are available. Each one gives you 1 hour of AMA credits. It's accredited by a Canadian organization, but we have a reciprocal agreement with the American Medical Association. So I think they're a value for both residents and staff. The way I use them here now is our residents complete them before we do these seminars, and then basically we turn the seminars into a case-based discussion. So I hope we can do the same sort of thing at your place.
Can nurses get credit as well?
So at our site, and something that you guys might consider as well, our emerge nurses are encouraged, required to do 8 hours of online learning per year. And in this last year, our management decided that 6 of those hours would be Jerry EM. So now all of the nursing staff at my hospital, Mount Sinai, have completed all 6 modules. And I can tell you the change in knowledge and in vocabulary and attitude among our nursing staff is pretty significant after that. So people, have nurses, I think, realize that asking a patient about function, how much they can do, and how that has changed over a short period or a long period, but that's really a very important piece of clinical information. It's not just checking how grandma is. It actually gives you a lot of information. And while we all sort of know that, making those kind of things explicit is quite important for care of the older patient.
So you've been working on the geriatric population for quite a few years now. What inroads have you made in Toronto and Ontario and Canada as a nation that is, or you perceive will improve older adult emergency care?
So starting from my own home site, I think our emergency department, Mount Sinai Hospital in Toronto, is could claim to be quite a senior-friendly emergency department. This doesn't mean we have followed the path of some places that have actually established separate geriatric emergency departments. On the model of a separate pediatric emergency department. My vision has always been that, as I said earlier, every emergency department is a geriatric emergency department, and that what's good for looking after old people is also good for all the other populations we look after. So, but I think, we've added a lot of things at our site that do make it a good place for caring for older people. There has been a strong commitment from our single-payer unified healthcare system in Ontario to improving geriatric care across the board, but particularly in emergency departments. And things that I'd talk about mostly would be the institution of what we call GEM nursing, geriatric emergency management nursing. So every hospital in Ontario, province of 16 million people, now has a specific role within the emergency department of a nurse-led case management who focus only on the older population in the emergency department. I think that's probably the main change. But I see it in all areas. I mean, there's a big move towards using paramedics and pre-hospital care personnel to be more involved in both in community care of older people. I guess another use of Jerry EM is I did a workshop and a talk at our provincial EMS conference this year, and as a result of that, all of the EMS technicians in the province have now also completed all 6 modules in Jerry EM, and both their leadership and I have had some really very strong positive feedback from them that they were a group who were aware that they were seeing a lot of old people and that they didn't know enough about them. And that Jerry EM has given them a lot of new information about their core group. So the EMS, I guess we're doing a lot of, at our site in particular, doing a lot of outreach work with our long-term care homes. This is another thing that is a perennial irritant to most emergency departments. Is the low quality of transitions between long-term care and emergency departments and back, I might add. And so we've been working with our main providers, because most emergency departments really only receive patients from 3 or 4 different long-term care or nursing homes. And working directly with them can often improve some of the quality of transitions that are happening. Those are some of the things that I think about.
Well, that's quite a bit of progress, and I'm sure that our audience in November is going to enjoy picking your brain and learning from your experience. I think that as ED directors and nursing leadership and hospital administrators look at the geriatric emergency department guidelines that were put out a few years ago, endorsed by the American College of Emergency Physicians and the Emergency Nurses Association, the American Geriatric Society, I think that they're probably a bit overwhelmed at the sheer volume of recommendations that are there. So what was the first step that you took to implement the senior emergency medicine guidelines in your ED and hospital?
So of course that's not the way it went, in that the guidelines came well after we had made a lot of changes over the last 10 years. And I think I'll address the overwhelming issue first, that there are a lot of good things that you can do. You can't do them all at once. Any of them are good things, so it doesn't really matter which good thing you do first. I think the most important thing is making a commitment to change and starting the change. Whatever you want to institute first, you'll do that, have some success, and move on to the next thing. And over 5 or 8 years, you'll have, through many iterations of quality improvement, you'll find that you're working in a very different place. So I would say the most important one is also probably the biggest change, and that is the introduction of some kind of focused nurse-led case management. As I said, we call it geriatric emerge management, and that's an advanced practice nurse who is qualified in both geriatrics and emergency care, who takes prime responsibility not for the medical assessment, but for all the other components of an older person's assessment. So the functional, the cognitive, and the social assessment, and for preparing the way for a appropriate, durable discharge from the emergency department. I think most of your places have some kind of case management in them, although I guess not all. And this is a big commitment to change, because it is hiring a whole extra person with the human resource and costs associated with that. But I think most emergency physicians working in the province of Ontario could not now imagine what it would be like trying to provide care for older people without the support of a GEM nurse. So I guess developing, and on that theme, developing some kind of an interdisciplinary approach to providing care. Every geriatrician knows that older people, any individual old person, is far too complex and has too many different problems for any one physician's brain to be able to deal with. Anybody can only hold 3 or 4 complex thoughts in their mind at the same time, and most older people, certainly showing up in an emergency department, have more than 3 or 4 complex problems. So in some areas of emergency medicine, I think we've been quite good at developing an interdisciplinary approach. Interestingly, for the rank and file of older person, and you're there at 3 a.m. You're really the emerge doc is really the only person with the nurse who is tasked with solving all these problems, and you just can't do it. So we have available to us, not in the emergency department all the time, but available to us, a geriatric physiotherapist, a geriatric occupational therapist, a geriatric pharmacist, and a full-time social worker whom we can ask for a consultation on any given older person. And as a result of that, and as a result of having that team available now for 8-10 years, there really is a sense of teamwork among them. So I know what the physiotherapist can do. He knows what I can do. We both do our jobs, but we also communicate, interact, make shared decision making. So developing some kind of interdisciplinary team that you have available to it, and that takes quite a lot of institutional commitment, because there needs to be that staff available, and there needs to be. I'm sorry?
They're available 24 hours a day for you?
No, thanks for clarifying that. They're available 8 hours a day, from 8 in the morning until 5 in the afternoon.
Okay.
So that's 9. And so to address that reality, we also then put in place a number of protocols and procedures for what happens to the patient who shows up at 3 in the morning or 8 at night. And so we have a practice of holding those patients overnight in our emergency departments, and they remain emerged patients until they can have a further assessment. There are clearly disadvantages of that. The old person has to lie on an emerge stretcher for another 8 or 12 hours. And emergency physicians have to look after that older person for that period of time and take responsibility for them. Those are clearly disadvantages. About way more than half of those people we're holding overnight are not admitted to the hospital and are discharged home or to a rehab, transitional care, or respite care bed the next day. So that's a huge win for everybody, for the patient, most importantly, that they don't get admitted to a hospital, which If you don't need to be in a hospital is not a great place to be. So it's a win for the patient. It's a win for the hospital because we don't have then a whole large number of people being admitted to the hospital unnecessarily. And everybody knows that once an old person gets admitted to the hospital, they don't go home the next day. They go home 4 or 5 days later. And I don't know what your places are like, but the main problem in Canadian emergency departments is overcrowding. And everybody knows that the main cause of emerge overcrowding is beds being blocked on admission units. So if you're filling up your hospital with unnecessary admissions of geriatric patients, then the downstream effect is immediate on the emergency department, and all emergency processes become slower and worse. So that's kind of taking a system approach to addressing one small problem in the emergency department. It has huge ramifications for the whole system, and the payback comes to emergency physicians in a number of different ways. One of the main benefits of changing the way things are done in the emergency department and giving your folks more resources to do their job is not only do you give better patient care, which is really nice, but the improvement in staff satisfaction is huge. So I don't hear people complaining about how many old people are lying around the emergency department or how complicated it is to get them out of the emergency department, because we actually have strategies in place where you're not working on it alone. You've got a team who can support you, and your success rate of doing the right thing is much higher.
Okay, excellent. So I've been working for quite a few years locally to try to bring some of these ideas to our city. And a big reason why I wanted to have this citywide symposium and bring in the two EM residencies that we have in St. Louis. And I'm wondering, have you, in your experiences, either locally in Toronto or going around Canada or the world with these ideas, encountered any barriers like ego-driven barriers, financial, logistical, other barriers to implementing senior-friendly emergency care into hospital systems? And if so, what lessons would you impart to others as to how to start to overcome those barriers?
So yes, there are always barriers. I think the first one that people talk about is financial. That people perceive change as costing money, and that we don't have any extra money, and it's not going to pay back, and so we don't want to make any change. And I think that's a very important issue to address. I think that is related to an important component, which is institutional commitment. And if you're getting that as your first component of pushback, that it's going to cost too much and we don't have the money, that really means that your institution, whether it be your department or your hospital as a whole, has not made a commitment to improving care of older people. And so I think that's where senior-friendly change has been successful. It's in places where there is an institutional commitment to that, where there's some kind of leadership with a vision that addressing the issue of senior-friendly change and making a better institution for older people is an important thing for this institution. At our place, we succeeded in pushing this right up to senior management, to the executive level, and beyond that to the board of directors, where the board of directors of our hospital said excellent care of older people is one of the top 4 priorities for our institution. So once that happens, and the president and the vice president of the hospital are told by the board that making senior-friendly change is a priority for this institution, then they pass that along to the managers and the directors, who pass it along to the director of the emergency department, and who are told, the board is going to be really happy if we do something positive for older people in the emergency department. So then, if it does cost another $50,000 off a line item on your budget, the rationale for spending that money is this is addressing one of the hospital's key priorities. So that's both a small thing and it's a big thing. Like making change at that level is really complicated. Once you do, then a lot of things get a lot easier. And how do you do that? I mean, I think most senior leaders are aware of societal realities. And the reality is that over the next 20 years, there's going to be a lot more older people in our institutions. If you were running a hospital and somehow you knew that over the next 5 years, your obstetrics department was going to be delivering 3 times as many babies, don't you think you would make some kind of changes to your systems and processes in your obstetrical ward? Wouldn't you be hiring more obstetricians? Wouldn't you be training more nurses in high-risk obstetrics, et cetera, et cetera? So we know that there are going to be a lot more older people in our emergency departments in the next 10 to 20 years. We've known that for the last 30 years. It isn't like it's a slow, gradual increase. It's actually the big increase is coming. And so most healthcare leaders are aware, just like business leaders, are aware of societal trends and changes, and I start making changes in advance of the disaster happening. So, in answer, going back to the original question, the main barriers, I think, are institutional commitment and hoping that you can make contact with leadership, whether it be just in your emergency department, your emerge leader, chief, nursing leaders as well, or at a higher level. If you can make contact with them and convince them that this is a change whose time is coming really quickly, then you're getting over the main barrier.
So it's going to be really important for us to have some administrators at this event in November, for sure.
It would certainly be the case. I also, as you're part of the faculty with our Senior Friendly Emergency Department course, which we've taught several times both in Canada and in Australia. In the needs assessments that I get from my Canadian colleagues, at least, institutional commitment is not the main problem that they report. The main problem is knowing where to get started. So just having the ideas, what are some good ideas that you can implement, what are the policies and procedures and staffing changes that you can make. So certainly getting your leadership on side and involved in this issue, let's not call it a problem, is an important first step.
Super. And so why should emergency physicians and nurses attend this event in November? We got a lot of competition for our time, and everybody's quite busy with clinical work and research and travel and family and very important things. And then why should geriatricians, hospitalists, EMS personnel, home health, dementia health care providers, primary care providers, why should all these people think about coming to this event in November from your perspective?
Well, I think we've already alluded to that, and I'll just state it clearly, because this is our job. This will make your life better. Getting better at senior friendly care will make your life when you're on duty better. It'll make you feel better about the way you do your job. It'll give you resources to do the things that you need to do every day. I say this, I'm a full service emergency physician. I do trauma and resuscitation and all that sort of stuff. But I say this continuously to our residents. You can practice your central line technique until you're the slickest girl on the block, but you're going to use that once every 3 or 4 shifts, if that. And you can get be the best ultrasound person or the best resuscitation person in your department. But unless you know how to look after the frail older person with non-specific presentations on 10 different medications and a tenuous social setting and a complicated discharge plan, unless you're good at that person, you're going to be in misery for half of every shift for the rest of your life. So I think it's really core emergency skills that we're teaching here. It's not some peripheral nice little add-on. It's core emergency medicine practice. And then, I think all those other folks you mentioned, one of the big problems in emergency care in general, and particularly with the older people, is this attitude that is prevalent in emergency departments that we are some little island of care that people come to and spend a bit of time on before getting shipped off back to where they came from. And we don't think of the emergency department as part of the continuum of care, that this is just one stop on the train ride of your life, to continue the travel analogy. And I think we need to get better at interacting with our upstream providers, primary care, and our downstream providers, long-term care, community-based care, the other specialists who are involved in providing care for this patient, and somehow be able to communicate more fluently and seamlessly in real time in the emergency department with all those people. EMS would be another good example. I mean, we need to make sure that EMS is on the geriatric bandwagon too, that they have the same skills that we're developing, and that we've got a good way of communicating with them. So I think those are the reasons that I would encourage people to participate. I think your geriatricians and your in-hospital people, your pharmacists, probably need to know more about what happens to old people in the emergency department. I work with a lot of geriatricians. I'm always kind of surprised that most of them have never been to the emergency department of their hospital. But it's a place where a lot of old people show up, and it really is part of the older person's continuum of care. So I think geriatricians need to be more involved in emergency department care, and I think emergency physicians need to be more involved in geriatric care. So those are things that I think people participating in improving their skills in care of the older people generally are happy that they have added those skills to their bucket.
Yeah, we have an exciting day planned. We have a very rich and full curriculum. We're going to be talking about ways to bring palliative care to your emergency department. We're going to be talking about the backdrop of the history of geriatric emergency medicine in St. Louis, because there is a history, and one of the early founders of geriatric EM, Doug Miller, is going to be part of the faculty. Audience members will have a chance to hear the speaker's ideas and short presentations, and then actually have a roundtable where you can ask questions and figure out ways to make things work within your healthcare system. So, and it's going to be a historical day. It's Election Day 2016. So historians may think that it's all about Trump and Clinton on that day. No, it's about St. Louis geriatric emergency medicine. That's what's going to go down in history. So
it's starting a new era.
It's going to be a landmark day. And Don, we really appreciate you making the trip down from Canada for that. Don and I will have just gotten back from Melbourne, Australia. So Don, really appreciate the quick turnaround time, flying home for a couple of days and then right back to St. Louis. But it's going to be well worth it. Thank you for your time.
Good. I'm looking forward to it.